Afternoon, doctors. On behalf of Hetero Healthcare, I, Dr. Prashant Khandeparkar, welcome you to this webinar on PPH prevention then and now. At Hetero Doctors, as you know, we market products in multiple therapy areas like in gynecology, dermatology, gastropulmonology, etc. We have a very strong R&D background because of which we try to develop products keeping patient benefit in mind. Our endeavor is to improve patient compliance and ultimately clinical outcomes. We have developed NSAID patches, rivastigmine patches for patient compliance. Gynecology, obstetrics, and IVF is an important therapy segment for us at Forenza. Apart from oral tablets like Didropal and Mylotin, we also market products for vaginal health like Feminora and Pelitra. Recently, we have also introduced a vaginal film under the brand name Silora, which is a lactic acid film and which is supposed to protect the vagina from getting infection. To keep the vaginal pH acidic. Doctors, as we all know, during our student days and otherwise, we have all studied about PPH. Recently, we have introduced carbetocin under the brand name Carbiac for PPH. We know PPH is potentially a life-threatening condition and requires intense management. To speak more about PPH and prevention with carbetocin, PPH management then and now, we have got today with us Dr. Vidya Bandukwalla with us. Dr. Vidya Bandukwalla is just one second. Dr. Vidya Bandukwalla is MRCOG, DNB, DGO, FICOG. Madam is founder member of Female Pelvic Pain Association. Madam is member of Global Interstitial Bladder Pain Society. Managing committee of Associate Fellow Gynecologist. Currently, the position hold is director at Touch of Joy Women's Clinic and Fertility Center. Consultant at Saket Maternity and Nursing Home. Besides all this thing, I want to tell you one thing. I had the opportunity and my good luck to attend, to listen to Madam's webinar on PPH with carbetocin. Such an intense topic, Madam made such a lucid way Madam presented. It was absolutely fabulous. She went into depth and everyone listened without realizing how much time they have spent. Madam, it was a lovely session. We once again welcome you to this webinar. All over to you, Dr. Vidya Bandukwalla.
Thank you so much, Dr. Prashant Khandeparkar. Thank you for all the kind words. And I think it always boosts a person, in the beginning to get kind words like that.
And I made all these are facts. There's nothing is made up.
Thank you so much. And thank you, Hetero Group, for, having me once again on this topic of PPH, which we as obstetricians are always, scared, nervous. Every delivery is, I believe, I tell my colleagues also, it's like, having a stress test, you clearing your stress test as soon as the patient delivers. So it's a topic which will be intense, not just today, like as you said, then and now, it's going to be now and future also. So can I share my screen now?
Yes, madam. Please.
Yeah. Visible? Is my screen visible?
Yes, madam, it's visible, but put it in the,
Is this okay?
Yes, correct, absolutely correct.
Okay. So thank you very much and good afternoon to all the doctors who have logged in, and I hope I can do justice to this topic of PPH. It's a huge topic, and each of us have had an experience sometime in our lifetime that we have come across a very, very bad, severe PPH, and we had to take a decision of how to go forward. And we had our limited drugs at that point of time. And we always look forward for a drug that would make a difference. And I think it's time that, with all the new changes that have come up, there is a change of mindset that we as obstetrician also should have to accept the newer versions of molecules, the better version of the molecule, which we have always been using, and that is oxytocin. So let's begin with that, going back to our basic physiological understanding of PPH. Yeah. So I think I gone ahead. Sorry about this. Yeah. So let's look at a very smarter, superior, and safer choice in PPH, which is what we would always want before and now also. So what are we looking at? We are looking at postpartum hemorrhage, the current scenario. We all know that it is one of the nightmarish condition or experience that any of us as
हाँ
obstetrician
अरे सर आपने मुझे ना आज मॉर्निंग के लिए कहा था मेरा अभी
obstetrician,
डिस्पैच
we
निकल रहा है
are
कब तक
all
आएगा
going
वो
through this. So let's begin with the current scenario. Then we will go to the risk factors of how we can, we know that no patient can be categorized to have a PPH because it is unpredictable, uneventful condition which can arise at any point. So at that point of time, how alert we are to recognize and how aggressively we treat is the key. And these kind of drills that we have in the form of CME is so important. I may be speaking, but unless I don't come across a case of PPH, it becomes very difficult to do what we have learned. And these kind of CMEs help us to, drill it in our brain that, yes, these are the steps we should look forward. What are the things that we need to do? Call for help, call for immediate help. Who are the ones we should be, immediately calling for help? Now, these are things that comes through a drill. And I'm happy and thankful to Hetero to have, to conduct these kind of CMEs, which help us to stimulate our own selves into a scenario of PPH. So let's begin a scenario of the PPH. Now, we all know that PPH means we expect that at least less than 500 ml of blood is lost following a vaginal delivery, and minimum around 1000 liters ml, sorry, 1000 ml is lost following a C-section. And we are aware that, our patient is good 11 grams, and we know she will drop her hemoglobin to 1.5 to maximum 2. She'll still be 9. But what about a woman who's starting her, pregnancy with a low hemoglobin of say 8 or 9? We are preparing. Now, this kind of patient is to be categorized into a risk factor. These are risk factors where we know that even if she loses 500, it's a loss for her and she will behave a little differently. So we all know that we are prepared in a compensated position while the delivery is on. And what is the compensation is we know that once the baby is out and the placenta is out, we know that physiologically the uterus will contract and retract and the loss of blood is stopped. But does it happen in everybody? No, not every birthing mother lands up with only a particular loss. There are women who can have much more. And that is where we categorize them as a postpartum hemorrhage. When the loss is more than 500 ml following a vaginal delivery or more than 1000, where we are going more than 15% of the body blood loss. That is when the compensatory mechanism of the body is haywire. It starts working against the body and you're not able to do justice to the body. So this is where we are looking, that we have realized that the leading cause of death, maternal death, one of the leading cause is PPH. And what are we looking? We are looking at a developed country and we are looking at developing countries. Now, as we know, India is among the developing country, the lower and the middle. We are still in the middle. And what are we looking? That in developing countries, it is 240 per 100,000 live birth. Is it even worth coming to a count of hundreds? I think we should be putting it down to, in single digits. Why should it even go to double, triple digits? So this is where we are looking. And what do we see in developed countries? It's just 16 over 100,000 live births. So let's look that 14 million women suffer from PPH. 14 million. Now, if we have good drugs, if we have good protocols, can we not get this million down? Can we not stop the incidence from 2 to 4 after vaginal delivery and 6% after cesarean section? This shows that how unpredictable it is and how difficult it is to assess which woman will go into PPH. And that is the reason we have to always be prepared with a patient who is birthing, where she needs to be delivered, how she needs to be delivered, who all need to be around. There are patients who deliver at home. There were times when we had home delivery and things were taken care. But how many losses were happening? How many mothers were lost to PPH? Those numbers are never been, considered. But today, every loss is a big issue. I mean, today we don't want to risk even 1%. How can we lose one mother to a PPH? So this is what we should question our own selves. Now, what is the incidence in India? What are we looking at? We are looking at 38% of maternal death, which is only due to PPH, out of which 25.7 of the global deaths take place in India, and 2/3 of these attribute to PPH. So again, the leading cause is nothing but PPH. And why? Because it was not identified, not recognized, and not treated aggressively. This is where I'm going to keep telling you that PPH cannot be just identified, but it needs an immediate response and it needs an aggressive line of management, to the extent that if you don't have anything, the answer is a hysterectomy. Don't even think twice. Better early than late. Better to have a life than to have a uterus which created a problem. So let's understand that PPH cannot be taken or in a very light way. It has to be very aggressive. Now, when we say that cesarean section versus vaginal delivery, we all know that there has been an upward trend in the C-section categories. We all know that the babies usually, before were much smaller, but today we have larger babies. We have the maternal age going to the extreme end. We have multiple pregnancies because of the ART protocols. So we are seeing an increase in the C-section rate, thanks to all these criteria that we have. So we have to be definitely more aware that patients can have an extra loss of blood. And are we ready? Is the patient prepared for that loss? How prepared is she? How much is her hemoglobin to even begin with? What is her hemoglobin at the time of the birth? So all these criteria can definitely allow us to at least categorize a low risk to high risk. But as I said, there is no risk. The low risk can definitely be high risk within seconds to minutes. And this is where we need to be aware of the PPH. Significant higher hemorrhage and observed in more women. That means C-section patients definitely have a higher blood loss, especially if you have a bad delivery, multiple delivery, where the patient was fully dilated and then in an emergency we have to take the patient for a C-section. You land up with a really bad, where both the uterines are lacerated and there's a upward tear. You definitely have more blood loss. Now, these are the times when you should be prepared. And if you want, you must leave your ego as an obstetrician and call for help. And your anesthetist, who's right around the corner, is the best person to help you doing this. So I think we should be more alert about this. So definitely there is an upward trend in the induction and augmentation, because as I said, there are a lot of changes in the era form of delivery that we have to be aware of. Yeah. Okay. So risk factors, and now we all know what are the risk factors which can lead to PPH. As I said, there is no the risk factor. Sometimes you have an over distended uterus behaving very well, and sometimes a normal uterus with a normal size baby can behave very badly. So it's very difficult to bifurcate the two, but nonetheless, there's always a risk factor which you should keep in mind. And those risk factors, which you have to know that there are 4 T's that help us to understand the PPH. One is the tone. Always after a patient delivers, what is the first thing we do is we always put our palm on the uterus, that is on the abdomen, and we look for the contractility, the retraction of the uterus. A hard ball feeling is the tone. That tone is lost in PPH, and that uterine atony, which means that the uterus is not capable to contract to its best. to help us, prevent the hemorrhage. But here it does not contract and it just continues to keep bleeding. Second is the thrombin, the coagulopathies with all different kind of, you see in PPH, in preeclampsia. These are the patients who land up with these kind of coagulopathies, failure to clot. Then there is trauma. If you have a vaginal birth with an instrument or a prolonged labor ending up with a, delivery, we have to be prepared that this patient will probably have a PPH. Again, lot of lacerations, a rupture uterus in a previous C-section patient, come in labor and you suddenly see that she's collapsed. We don't know. It could be a concealed hemorrhage. Then uterine inversion. A lot of the time there is a uterine inversion and patient just collapses. So we have to be prepared to understand these and identify these causes. Then there is tissue. What is tissue? If the placenta is delivered, we have to make sure, in case by chance, before you land up and the patient has delivered and the nursing staff has delivered the placenta, make sure that you see the placenta for the completion, that we are not missing any cotyledons and, having some retained products. Now that could give you a very bad abnormal bleeding and a tonicity. So these are things that as an obstetrician, we should be aware, and there is a never event. You cannot say that I missed it. It cannot be missed. These are our protocol and it has to be a basic protocol in the labor room. Now, talking about atonicity, in fact, if you look at this, 70% of PPH is always because of the atonicity, whereas 10% is because of the retained tissue, 20% is because of the trauma, and it's only 1% because of the thrombin. And of course, with the newer version of handling a PIH or a preeclampsia, things have got better. That means if we are ready to accept drugs for PIH and preeclampsia, and things have got so much better, why not, be open for newer drugs in a atonic PPH is what I want to speak today. And I think everybody of us has gone through this phase of PPH in our studenthood life and as a consultant. And we all know it is so scary. When the patient is yours, you could be an expert in talking and, speaking and giving your advice to another colleague. But when it happens to you, you actually go into a brain fog. You cannot figure out how to function. But that is the time when you have to gather yourself and you have to actually estimate the blood loss. You rather overestimate than to underestimate and call for help. This is very important. Always be very aggressive on this front. Never take PPH as a simple event. It can, from the simple, it can just go complicated. So uterine atony being the most common, almost 70%. Now we know why uterine atony could be the most common thing is there are risk factors. And these help us to actually categorize them in the beginning. If you have a patient with polyhydramnios, if you have a fetal macrosomia, so it's say in a diabetic mother, this baby is going to be large. In multiple pregnancies, other kind of uterine inhibitors that are used. History of uterine atony in the past, any history of PPH. Whenever we take a history, make sure you know about her last pregnancy in detail. It is always better. About her past PPH history, about the weight of the baby. All this helps you in the current scenario of her delivery. Multiparity and the age also matters. We are seeing maternal age also going up. Then multiparity, definitely multigravidas have a more this on uterine atony, and of course, a prolonged labor, as I just discussed it. Again, the risk factors are retained placenta, multiple pregnancy, progress in the second stage, that is a prolonged labor, again, prolonged third stage of labor. Now, in this prolonged third stage, there was a time when we used to all wait for the placenta to deliver. It was the physiological way of the third stage. But after a point, even the government realized, even the consultants who were with the government realized, by doing a physiological waiting period, we lost more blood. And for what? The blood just went for waste. Instead of that, why not do the active management of the third stage? Why should a woman even lose that 100 or 200 ml of blood, which is of no use to anybody? And that is when the third stage was taken as an active management. And we all now believe in the active management of third stage, where you have a control cord traction and, keeping your hand on the uterus, pulling it backwards and controlling the traction of the placenta and making sure that the placenta is fully come out. And that's so important. Giving a timely episiotomy is so important, rather than waiting for a tear and a laceration to create more problem for the woman. Again, there are certain conditions of placenta accreta and all. These are now touch wood because of the ultrasound machine being, the different changes that have come up with the ultrasound, the better modalities that have come. We are able to understand accreta and a percreta today. So today, thankfully, a previous cesarean case patient, when she comes, we always look for the location of the placenta. And if there is a placenta located anteriorly towards the scar area, we have even the MRI that can help us to understand this, and we are prepared with such patients. These patients definitely will need a tertiary care center and never a nursing home or even a home delivery for that matter. Preeclampsia, as I said, with again better drug treatment and better understanding of preeclampsia, we are able to manage these patients in a good tertiary care center. Previous PPH and a case of general anesthesia, where we are so used to giving spinal anesthesia that we have forgotten that in general anesthesia, there's a complete relaxation of the uterine muscle. And these patients are much more prone to PPH than a patient with a spinal anesthesia. Now, these are things we must be aware. Fetal macrosomia, as I discussed with you, and a laceration. A timely episiotomy is always better at the right time. You give a straight cut, clean episiotomy. It will save the woman from all the disasters that she will have in her future. In low risk population having vaginal birth, most women develop PPH have no identifier. This slide is so important that you cannot ever say that this woman will not land up with a PPH. There is a never say never attitude. You will never know that when her criteria will change, when her low risk will become a high risk category. So it is always be prepared for the worst. Induction of labor, definitely there are chances of increase because we have a prolonged labor in such cases. You have a Bishop score which is poor. From a poor Bishop score, for her to get into the level of cervical priming and then into the labor process, this is a long protocol. And so she definitely will have an increased risk of atonicity. Labor-inducing drug might have a direct effect on the uterine muscle and act as a fatigue factor, which we all know that even an exhausted fatigue patient can behave very differently as compared to a patient who is not fatigued. So it's so important to give them liquids and, keep them hydrated. So labor per se itself is so important that, in a laboring patient, you must make sure that her pain is relieved in the right way. Her hydration is well maintained. Such patients behave also very well. If a patient is dehydrated, exhausted completely in the end, one is she is not able to bear down, and so we need to use her instrument to help her in the bearing down. Second, such patient definitely will land up with some laceration and their uterus also behaves very badly. So I feel every laboring patient should be taken, I would always say as a woman, I would love to be labored in a place where everybody is, giving me the importance of not going through too much of a hassle of laboring. You must make her journey of motherhood so much of care and support. And that is not just at the end, but even from the beginning. And these beginnings will definitely have a good ending. So what are we looking at? When I say we have to pamper and support a patient who's in a labor, what do we want? That she should end up her labor in a good way, have the delivery, deliver the placenta, have the uterus well contracted, and have a peaceful, postpartum period. But what will happen if the patient ends up with a PPH, which is unpredictable? What can happen? Her stay in the hospital will increase. She will have higher mortality due to other risk factors. She could end up with a bad, severe PPH, end up with organ failure, multiple organ failure, blood transfusion related distress and reactions to that. all this will definitely impact not just her, but her baby and the relatives and family around. So you're not just seeing one person who's birthing, it is the whole family who's involved. And along with that, the birth of a new baby who will be away from his mother or her mother because of the PPH. So look at it that the impact is much, much more than what we even can think and imagine. And she will definitely have a trauma, a post-trauma stress. It's a difficult scenario for a woman to even think of having another baby with the stress that she will go through this. So PST is very common in these kind of patients. So how can we prevent all this? Now, apart from causing mortality, can PPH lead to other morbidities post-delivery? Yes, of course. Of course, we just spoke about it, that she is a candidate who will definitely go into postpartum depression. It's a very known this, that if a patient has had a bad delivery or had a bad experience, even in a normal scenario, what do we see? We see that patient having an aversion to a condition which is similar to what she's gone. So this depression is very, very inevitable in a patient who's had a PPH. She could have a very, very heavy flow and her anterior pituitary could go into ischemic changes, the Sheehan syndrome, where she could have a failure of lactation and sometimes go into amenorrhea. So these are the points we have to keep it in our mind. She will land up being so anemic, even if she's received blood transfusion. Her body has to still get back to her normal. So she'll end up being anemic. She'll be fatigued, exhausted. She will receive so many blood transfusion, then blood transfusion related, airway distress. All this are common. Then myocardial infarct. These are commonly seen in the severe category of PPH, dilutional coagulopathy. And eventually, when all the organs fail to, compensate and work towards her well-being, we have even lost patients. So let's not, work towards getting into this level. Let's work towards preventing, aggressively identifying, overestimating rather than underestimating such situations. In absence of identifiable risk factors, PPH prophylaxis is the best way ahead. I am sure all of you who are hearing me, this is something we all dread, that once a patient delivers, what next is always in our mind. And this is important because we will save this woman from all that we discussed in the past slide. So PPH prophylaxis is the way forward. We have to have drugs that will help us in the contractility of the uterus. That's all we need, because 70% of the PPH is because of a tonicity, and it is in our hands that if we can help in that tonicity, why not? As I said, even trauma, if a laceration can be prevented by a clean-cut episiotomy, why not give a good episiotomy? You don't have to give a big episiotomy. Sometimes all you need is a small episiotomy and a good way of delivering the head, a good way of delivering the baby in all the possible maneuvers that we have been taught as students, and prevent the laceration. Look at the placenta incompletion, whether we are missing a cotyledon, we have not missed, is there a succentrate lobe that we have missed? All this will help us prevent. So why not do a basic understanding, have an understanding that this is ABC. We have to get this done in the labor room once the patient is birthing. Period. This is how we can identify and help and prevent and act as a prophylactic way of preventing a PPH. So PPH prophylaxis is recommended for all women. So as I said, that there is no more physiological waiting. It is always an active management of the third stage. Due to uncertainty of PPH, the healthcare provider must be prepared. As I said, our antennas have to be always on. We cannot say ki yesterday night I had a case and I'm exhausted and I missed it. No. If you have missed it, it will always be on your back that you missed a case which you could have prevented. So always remember, if you are not in a frame of mind, make sure you always have a colleague with you. Or if you realize that there is a PPH happening, don't underestimate. Call for help. Call for as many help as possible. There has to be, your nursing staff have to be smart enough to understand what is. So such drills have to happen in the hospitals, in the nursing home. They're so important because they don't come knocking. They just come immediately without giving us any kind of, understanding. So the uterotonic is administered before the delivery. Now we have to understand that the third stage has to be managed where the cord is controlled and pulled out. After that, the uterus has to contract. Now, in this, we use oxytocin in the form of, sometimes we give them intramuscularly and sometimes we give intravenous. So we give 5 international units. And in that form, we can also give the infusions. Now, we all know that the half-life of oxytocin is much lesser as compared to what the newer drug is all about. So we will come to that in the later slides. But is it possible to prevent PPH? I think we all can answer and say, yes, we can. To the level of drugs and knowledge that we have, out of that 70%, we can definitely come down to even 10% if it is timely done and it is aggressively managed at the right way. So our response is so important in preventing a PPH. Now, what are the measures that we will look at PPH? We know that in antenatal period, we have to be sure that we correct the anemia. Today, with the intravenous management of iron infusion, we are all so happy. We are also happy that we give the patient 1 gram of an FCM. And we know that in 3 weeks, this patient will have at least 1.5 to 2 grams higher hemoglobin. So why not correct her hemoglobin? Why not correct her nutrition? Okay, always identify the high risk factors. Have a regular check of the patient. Make sure that these patients are called at regular intervals so that we know. Always get a complete blood count very close to her delivery. We usually do this mistake. We do a blood count in the beginning or maybe just mid, but towards the end, we never do it. How can we be so sure that the woman was compliant with her medication or she was actually well nourished? It's so difficult in a rural area. It is so difficult in a 2-tier city where you have a volume of patients coming to you. So we have to understand and categorize these patients and give special focus on such patients. So appropriate place of delivery, as I said, today there should not be any room for home delivery, whether it is in the rural places, there it should be a big no. Because as I said, PPH does not come knocking. It is always something. Imagine a person staying in a rural area where a PPH is identified. That person to reach a tertiary care center, even in a vehicle, will take nothing less than half an hour to 1 hour. It's our golden period. It's like the golden period for a heart attack and a stroke. If you miss that period, you have lost your battle. You can be in the best of the hands. You can be in the best of the place you reach. But if you don't reach timely, nobody can help you. And so is the case here. So I think today, as obstetrician, we must vouch that all our patients should be encouraged to have a hospital or a nursing home delivery. And even in a nursing home, if you feel that a patient is high risk, please make sure that this patient is referred to a tertiary care center than to deliver on your own here. Now, what do we look at intrapartum? I kept telling that active management of third stage of labor. Yes, this is what is now the protocol of the third stage management. What are the drugs that we use? There are drugs that have come. Misoprostol was never there before. It was in the last 10 years that misoprostol came into. So we use misoprostol for cervical priming and its role in PPH. There is a single dose, 600 microgram per rectal that we normally use in patient, and we use even sublingual while the patient has PPH ongoing, simultaneously. We have used carboprost. We have given intramyometrial also to get a better result. Now, what is the newer drug? The carbetocin. Let's look at what carbetocin can do good over the drugs that we already know. And as I said, we must have a mindset to accept new things. If we have accepted newer things, even misoprostol was a newer drug at one point. Even PGF2 alpha. These were all newer drugs. We accepted it and we made our lives so easy today. Even to prime a cervical cervix, any kind of abortion today, we always prime the cervix and we are so happy with the results. So why not use a drug that can give us that kind of happiness? And it is not happiness for us. It is for the well-being of the patient. Ultimately, we as doctors are always wanting to do the best for our patient. So why not, accept the new change? What do we do in the postpartum? As I said, always look at the uterine tone by putting your hand. Just the feel of the uterus will let us know that, yes, this has a good tone. And if the patient is still bleeding with a good tone, yes, we know that she has had some trauma somewhere. She's probably had a cervical tear, or she's had a high vaginal tear, or she is having some vaginal, hematoma collecting, which is not revealed and it is concealed. Such patients should be taken into an OT. Call for an anesthetist, because sometimes they do not help us. The patients are, they're so exhausted that they don't allow you to touch them. In good illumination, under a good this, you must explore and see where the trauma is. Now, these are all things that can help and prevent a PPH. Use the right uterotonics. We all know that oxytocin was used, but oxytocin alone has sometimes failed. And have we ever thought of why it has failed? Do we all question that? No, because we always knew that oxytocin blindly was given, and oxytocin given 40 international units. It was given 100 units tak bhi de rahe hain. But what have you achieved? Sometimes we have not realized that oxytocin needs a cold chain. And if the cold chain is not in line with the way it has to be, you have degradation of the product. So you are using a product where the effectiveness is so poor. So even an infusion of 40 will not give us the result. And hence we have to use a combination of different drugs. We have used multiple drugs. I have sometimes used oxytocin. I have used methergin. I have used carbopros. I have used even misopros, a combination. And then I have felt relieved. Oh, now I've given my masala and now I'm fine. But have we ever questioned why the oxytocin did not work? And why did we need to use all the 4 drugs? So this is where the answer is. Now, in the level of the Ministry of Health and Family Welfare, the Government of India, what is the effort? We are all looking at reducing our MMR. We do not want to be in the globe as one of the leading cause of maternal death. Why should we? Where India is doing so well in all the other faculties, why should we be in the maternal mortality? Why can't we reduce it? And who will reduce it? Each one of us. Each one of us is contributing, maybe not, but towards that cause. So let us work towards it. Let us correct the anemia. Let us give them the iron prophylaxis that they need. Nutrition wise, treat them. If they have, deworm them. Most of the rural places, the women are always having worms. Deworm them correctly. Give them the right nutrition. Have a dietitian who can help them. So effectively management of the high risk. Identify the high risk patients and give them special focus. These are all. Lakshya is one of the initiatives which helps in all these. Then the active management of the 3rd stage. Then maternal and newborn health kits. These are all the kits and everything that the government is actually doing to help the women get help at the right time. And they have to be convinced. So there has to be, when you have these ANC classes, they are not some joke. They are classes where people actually are taking time off to understand what a patient requires. So, and educating those patients, because we have to understand they are lay women, they have no education, no background. We are allowing them to understand what is happening to their body with pregnancy. What are the changes that happens when a patient is pregnant? And what hemodynamic changes are expected at the time of birth? So all this, if we educate a woman, there will be a fear to her that, yes, I need to have a good nutrition. I have to have a good hemoglobin level at the time of birth. And this will help us prevent and decrease our maternal mortality rate. And what are the practical problems we are reaching? As I said, all the rural areas have home delivery, and they are very proud of it that, the dais come and they do a good job. But have they ever reported the numbers of losses? Nobody wants to talk about that. Delay in reaching. You have a home delivery or you have a rural area where there is no ambulance, no way to commute. These patients take 1.5, 2 hours to reach. What happens in the 2 hours? You're gone. You've lost more than 25-35% of your blood. And what do you reach there? To only be declared dead. So this is where we need to educate our young mothers and the family, not just the mothers. Delay in receiving care. It's that even if you reach after 2 hours, what is the point? Again, why delay? Because you didn't recognize. You underestimated. You should always overestimate. You must realize that this is not a simple loss of blood. It is something that we have to act upon. All the T's have to be put forward and say, where does this belong to? Does it belong to a tonicity? Does it belong to a tissue trauma or a thrombin? All this and delay in decision. As I said, if you're in a smaller sector and you have no availability of blood products, no availability of any experts, it is better to resort to an invasive hysterectomy and save the woman than to just, have the uterus and let the woman die. So I think these are some key points that I would like all of us to ponder upon. So what is the best way to, practice? Always safe practice is the best practice in PPH management. So you must improve the health status of every mother. Every mother. We know that there is hemodilution in the pregnancy. So even if the patient is at 11, make sure that she is supplemented with the iron and make sure that she's compliant with the medications. Identify the risk factors. Plan for a delivery if the patient belongs to the high risk. Make sure that she reaches the tertiary center. Strict vigilance of all the women. Never take any patient lightly. Every birthing mother is of utmost importance to us. Each and every mother. So keep a strict vigilance, even if you're not around. It's not possible for an obstetrician to be 24/7 in a labor room assisting. Make sure your staff is well versed with all the vitals that are required to be recorded. And she should be the one who can alert. You see, there is an action line and there is an alert. You must know when is the alertness to be there. So these are the management. These drills have to be done in our nursing homes so that, we don't miss such patients. Always practice active management of the third stage. Examine the afterbirths. As I said, sometimes it's inevitable. A patient may have a precipitate labor and, you may not reach at that time. Your staff has delivered the placenta because eventually the placenta comes out and she must have not seen a missing cotyledon, and this is where we will miss everything. So make sure that you always examine even if you have delivered the patient. Explore the uterovaginal canal following any kind of instrumental delivery. We have been taught as students to always see that the cervix is not torn after an instrumental delivery, and I think that practice should well be taken forward. We all know that in the active management, the third stage of labor, no physiological management anymore because we have only realized that there is loss of blood, which is of no use. So active management can be done, and the way it is with the help of uterotonic agents, which help in contraction and retraction. The delayed clamping is one. It helps in all the pediatricians now prefer the 1 minute delay of cord clamping and to do the control cord traction whenever required. Assess the uterine tone immediately to ensure that the uterus is contracted. I think the whole last 15-20 minutes I've been just, highlighting on this part. Must assess the tone of the uterus. This helps us in understanding what is going around. So a large WHO-directed multi-central clinical trial has highlighted the use of uterotonic as the most important. So this is where I'm saying the uterotonic drug has made our life so much easier with the PPH management. How important is the stability of a uterotonic? Now, this is where I said that we are using oxytocin so blindly without even realizing that its effectiveness is lost. The minute the cold chain activity is gone, the effectiveness of the drug is lost. That is the reason that in these rural areas where, or even in a 2-tier, 3-tier cities where they don't have proper electricity, where the electricity is lost, sometimes even their refrigerators are not well kept. So how do we expect, in these cities, forget even in these cities, even in a city like Mumbai, in a small nursing home, you may not have the right refrigerator to do the needful. So you are losing the effectiveness. And the only thing you are harping is, oh, I use oxytocin, I use methergin, I use misoprostol. What is the point? You have used so many drugs. And you have spent much more time, energy. Ultimately, you have a drug which is working towards that, and you are not even wanting to learn more about that drug because you're so happy with the 4-drug combination, which ultimately works out, it's like a penny wise, pound foolish. You want to have lots of penny lost rather than one. So why not have one single drug that can act effectively at a given point of time without the use of any other drug? So stability, yes, is very, 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 very important. Use of poor quality uterotonics during the third stage. Now, there is no poor quality. None of the drugs are poor quality. I'm not going to talk about the quality of the drug, but the effectiveness is lost when the cold chain storage is lost. And that is something we have to understand. So why not have something that is room stable, temperature stable, which knows that it cannot be degraded even if the temperature is changed. So we need a stable room temperature drug that does not change its identity, its configuration when the temperatures are changed. Even in a hot country, if you have a city with like Rajasthan, or if you come to a place where you go to Kashmir where it is cold, there it is stable, it is heat stable. From there to there is no change. So why not use a drug which is stable? Though it is a little more expensive than oxytocin, it is giving us the best result, because here we are talking about life and death. And when we are talking about life and death, would we even think twice for our own selves? Then why should we think twice for a patient who's delivering? So the failure to prevent PPH will have considerable consequences for both, not just the woman, but it is reflecting on the healthcare system that we couldn't give the woman the right drug. The effectiveness of the drug, we couldn't even make out. So what are we looking at a woman? Why are we looking that, hemodynamic instability and organ failure can ultimately lead to that? We all know it, that if a woman has lost more than 25-35% of her blood, what is it? However timely we give, she's already had an acute kidney injury. Her heart is already compromised. Why should she reach to a point of not being able to reverse the condition? Risk associated with blood transfusion, massive blood transfusion. We all know that massive blood transfusion have its own adverse effects in the lungs everywhere, ending up with a hysterectomy unnecessarily sometimes. Thromboembolism, we know with all these conditions, she could end up with an embolic episode. Sheehan syndrome, Asherman syndrome. Why should a woman end up with all these if we can prophylactically save her from it by using a right drug at the right time? Of course, healthcare, it reflects so much. Use of higher number of units of oxytocin. We've always been taught 40 units or 20 dalo. And what about the oxytocin effect when it comes to hyponatremia, where we will lose her to hyponatremia? So these are the times that it reflects on our understanding of a drug, our understanding of a condition. So admission to an ICU, where all these patients, if we cannot treat them at the right time, she loses a lot of blood. You give her blood transfusion, but she will definitely end up being in the intensive care, or she will be in high dependency unit where she needs to be nursed for the next 48 hours to see that she is back to feeling normal. Her vitals are within the normal criteria. Her kidneys are functioning well. Her airway is good. Now, this will definitely impact not just the mother, but even the baby, where the baby will be away from her mother. Her lactation will suffer, everything put together. So it's a poor outcome of delivery. Surgical interventions, unnecessary hysterectomies are done. Huge blood transfusion, longer time in labor ward. The staff involved becomes, the numbers increase, longer hospital stays. So ultimately, the reflection of our birthing just tells us how much poor it becomes. So let's not look at that kind of poor outcome and be more responsive, be more aggressive in such conditions. PPH treatment, some women still require treatment for PPH despite active management. Yes, we all have seen this, that even after having active management of third stage, we have had the need. Now, again, I will come back to the need would be because maybe our uterotonics were not effective at the time of infusion or giving them. So these uterus will not behave well and will require other combination or other drugs. PPH treatment may be required where no preventive agents are available or after failure of all other uterotonic drugs. Now, what are the usual way of treatment? Oxytocin, misoprostol, and the prostaglandins, which I think it is the guideline that gives us that these are the drugs to be used. The newer ones are the antifibrinolytic drugs like tranexamic acid, which has been now introduced. I mean, not recently, but has been introduced. It gives very good results. Uterine tamponade, we know that the compression by manual, rubbing on the uterine fundus, and then balloon tamponade, all this has helped. But sometimes they all fail. And the end result is surgery. So it doesn't say that you use a drug, a newer drug or an oxytocin and things are only better, but it will at least, if 7 out of 10 women go into PPH, at least you can save 3 or 4 of them, and maybe 2 will just require the end hysterectomy. So why not prevent the 5 is what I want to put forward today. Now we all know that 10% loss, the body will show no change because it has a compensatory mechanism to overcome the loss. 500 to 100, that is 15%, still nothing. But when it goes beyond 15% loss, we start looking at the kidney issues with decreased urine output, increase in the pulses. So the heart is trying to beat faster, push more blood into the circulation, increase in the respiratory rate for more oxygenation, leading to postural hypotension, and the pulse pressure becomes very narrow. When it goes beyond 30, 35, what are we looking at? A complete hypotension, tachycardia. So you're putting more load on the heart. The kidney has gone into complete injury. And then beyond 40%, there is a profound shock and there could be a multiple organ failure and the patient could just go. So before we, our action light should start when there is a 15% loss. We should not wait for it to go to 20%. So what is the challenges that we are seeing today in our current therapy is that oxytocin need to appropriate training to the clinical staff. Of course, training is the must. Every staff in the labor room should be well versed with all the uterotonic drugs and the management of PPH. Regular patient monitoring, shorter half-life, need for other use. We know that oxytocin has a shorter half-life as well as the efficacy of it depends on the cold chain management. Symptometrin, we cannot give in a patient who has a PIH. And the side effects are increase in the blood pressure, severe nausea, vomiting. Oral misoprostol cannot be used in certain asthmatic patients and its other side effects here. Again, methyl ergometrin, combination drugs, all leading to severe nausea, vomiting. I don't think any birthing woman would want to experience a drug that causes her a GI effect. Nobody wants to have nausea and vomiting. Why would a patient who wants to just deliver end up just feeling nauseous and vomiting, retching, when she wants to actually hold her baby and feel so cozy with the baby? So I think these adverse effects should also be cut out, and we must accept a drug which has a better compliance with the patient. So what does WHO recommend? It recommended an effective uterotonic for the prevention of PPH during the 3rd stage. To effectively prevent PPH, only one uterotonic should be used, which is so true. Why should we use 4 drugs when we can use one single drug and do the needful? So as I said, should never be a shortcut. It should be a understanding of the drug, and never, anything new comes, please learn about it. Don't just say this is not the drug. Oh, it has just been tried and tested. We are not sure. No, every drug has been tried and tested in the right way. When it comes into the market, it has been approved by the best of the best societies. And that is where it finds its place in a country like India. And why in India is because we are still the highest in the global scenario for the maternal mortality rate. And we all should pledge as we pledge towards, eliminating anemia in our country. Why not eliminate PPH? Why not? So why not pledge for this? Uterotonics to be used. Of course, oxytocin and carbetocin has been written in the newer WHO recommendation as a prophylactic drug. So why not have a single drug that has its efficacy even in a stable room temperature, does not need a cold chain? I'm not saying that oxytocin is superior. We have to know that they are sisters. They are of the same category, but the efficacy is lost. And where the efficacy is lost, the whole scene is lost. So why not have a drug which has all the efficacy built in? There was a time when carbetocin also needed a cold chain, but now with the newer invention of it being stable at the room temperature, the newer way it is made, I would embrace it. And I have embraced it almost a year back, and I've been very, very happy. In fact, today morning I had a delivery, and I'm not even lying. We just, as soon as the baby was delivered at the anterior shoulder, the nurse was at the IV end and she gave the carbetocin. And as soon as the baby was delivered, the cord clamped, the placenta was almost out. So it is so potent that, the uterus contracts and retracts to the extent that the placenta is almost out. Even in a C-section, we need not even pull. It just is out. It's like you deliver me, asking us that I'm out, you just deliver me. It is that scenario. Of course, there could be 1 or 2 patients where we have to use our active management, but most of the time, it automatically pushes the placenta out while it retracts and contracts. So that is the beauty of the drug. What is the rationale for the development of carbetocin in new heat stable? I just spoke about that it is available in room temperature stable formulation and it's convenient while presentation. Again, oxytocin needs a refrigerator to avoid its degradation. Heat stable formulation is still not available for oxytocin. Previous formulation of carbetocin required a 2 to 8 degree this. Now, with the room stable, it does not require that. Poor countries, resourceful countries do not have the cold chain transport. So can you imagine? It is so sad that these countries where we need, actually we have anemic patients in those places and 2-tier and 3-tier, where we have women at 8 grams and all coming and laboring, and we are not able to give them the right drug, right uterotonic to prevent them from PPH. So let us not, lose such patients. Just because they are uneducated, we cannot behave like one. We are educated, we have been taught, and every life matters to us. Every woman matters to us. So we must give the best to anybody who is under our care. Again, the best effectiveness is stable at room temperature, half-life or has shelf life of 24 months at 30 degrees and 75% humidity, avoids the need for cold chain storage, and is provided in a vial. Now, let us have an overview of carbetocin. We spoke enough of PPH. We understood what is the percentage loss of the blood and what are its repercussions, and what is its impact on the patient as well as the whole community or the family. What is so good about carbetocin? As I said, quality-wise, I will never put, there is no superiority of oxytocin over carbetocin or carbetocin. It's like siblings of the same family. We are just talking about the stability, the efficacy, and that is where carbetocin has a better, overview of being the better version of oxytocin. So carbetocin was created by making several modifications to the oxytocin structure, which helped in prolonging the half-life and reducing the enzymatic degradation in the temperature related. So it does not need a cold chain. So that is the superiority that we are talking about, carbetocin over oxytocin. It is synthetic, long-acting analog of oxytocin. As I said, sister concerns, therapeutically prevents PPH due to uterine autonomy. It is never used for induction. Just as oxytocin can be used in augmentation and induction, carbetocin cannot be used for induction and augmenting of labor. 1 vial contains 100 microgram of carbetocin in 1 ml solution of the injection. Now, what is the mechanism that we are looking at carbetocin? It binds and triggers activation of phospholipase C and the generation of the second messengers IP3 and diacylglycerol. IP3 induces release of free calcium from the intra. We know the musculature and the calcium chain in that, how the contraction of the muscles happen. Binding of calcium to calmodulin stimulates uterine smooth muscle contraction by activation of the myosin light chain kinase. So just a single dose of the carbetocin while the patient is delivering at the delivery of the anterior shoulder is enough to maintain an adequate uterine contraction, preventing the atonicity and excessive bleeding with efficacy comparable to hours of oxytocin infusion. So what do? 5 units is going, we add another 5 units, 10 units is going. If the patient is still bleeding, add another 10 units. Along with that, give Mithergin along and be sure she's not PIH. If she is PIH, you cannot give Mithergin, then you give Carbopros, then you use Mesopros. So it is so many drugs, so much of time wasted only in preparing the drug and giving the patient. We are wasting almost half an hour and allowing the patient to bleed so much more. Why not use carbetocin and prevent that half an hour also? Why should we brainstorm so much when we have a drug that is helping us, easing us with all these criteria? So what is the benefit of heat stable? It reduces the need for uterotonic agents, as I spoke just now. No need of cold storage, good tolerability, good compliance, no adverse effects, and the efficacy is almost similar. It has a longer half-life. Imagine an IV carbetocin, the duration is 60 minutes as compared to just 30 minutes in oxytocin. Half-life is almost 40 minutes compared to just 3 to 5 minutes. So we have seen what is the superiority. Okay. Now, carbetocin is 24-fold less potent than oxytocin at the vasopressin. So we discussed it last time that patients land up with hyponatremia and the side effects or the adverse effects of hyponatremia. We all know how the hyponatremia, water retention in the body can lead to the disturbance. So any disturbance in sodium, we have even witnessed in patients. So oxytocin has antidiuretic effect, and IV infusion will cause water intoxication and its acute form of hyponatremia. So this is prevented with carbetocin. So imagine while you have oxytocin and you're just giving the patient 10, 20, 30, 40, because at that point you don't want to think anything else. And there is nobody else to tell you. You end up overloading with oxytocin and the water intoxication. So this is where we can again talk about the superiority of carbetocin over oxytocin. The hyponatremia is completely eliminated with a carbetocin drug. Now, let us talk about the clinical evidence. We are almost come to the last part where I am just going to review about the literatures that have been, So we have almost 1, 2, 3, 4, 5, 6, 7 literatures, which actually gives us the understanding. The first one is with the efficacy and safety as over oxytocin, then carbetocin being non-inferior to oxytocin, which was a huge champion trial where even India was one of the participants. Carbetocin decreases need for other uterotonic agents versus oxytocin, single dose carbetocin over continuous infusion comparison. I think I have discussed all this over the past slide, so I won't go in a deeper understanding. But as I said, the champion study had India. 30,000 women were enrolled across 10 countries, which included India. So we have been a part of this study, and so we can talk about this drug. Okay, the proportion of women with blood loss of at least 500 ml or the use of additional. These were all the criteria and the results that were taken into consideration. So you can see what was it. It is almost similar. So it's not that it is superior or inferior or anything, but just the stability and efficacy is what I'm talking about. And because of its efficacy and stability, the need for other uterotonics to be used along with carbetocin is nil as compared with the oxytocin, and I will go on highlighting about it. Again, the second, where we know that it decreases the need for additional combination of drugs as compared with oxytocin. Hemodynamic effects of oxytocin were compared and they had almost similar. Early hemodynamic effects were assessed as impact on blood pressure, additional uterotonic agents, blood loss, drop in hemoglobin, additional this. So all these studies have been done with the definitive groups who received carbetocin and who received 20 international units of oxytocin. Carbetocin and oxytocin, they have a hypotensive effect. Women treated with oxytocin showed greater reduction in the blood pressure as compared to carbetocin. Significantly more women treated with oxytocin needed additional, again, coming back to the same thing, and patients treated with carbetocin showed better uterine contractility at 2 hours, 12 hours, and 24 hours, with statistically significant difference between the two drugs. So you can imagine that the half-life being so long has helped them to keep the contractility of the uterus and maintain the tonicity as over oxytocin, which is given in the infusion form. So in this randomized control trial, what did they find? That management with carbetocin is associated with a greater reduction of PPH as compared to the oxytocin. The carbetocin, a good alternative in PPH. Again, another study, they actually seen the blood loss over 24 hours. What did it do? It significantly decreased the risk of manual removal. As I just spoke in that my morning patient, I didn't even need a controlled cord traction. The placenta was right at the perineum and I had to just deliver it. Especially in women with induced or this. Carbetocin has 83% probability of being the best agent to reduce PPH. That is, it decreases the blood loss to less than 500 after vaginal. What more do we want? I have actually seen just a loss of 150 ml instead of even going up to 500. The advantage of its application at the end of the third stage of labor was that it decreased need for uterine massage and the need for other. So we don't even simultaneously need to go to the first line of treatment of PPH. It does the needful that, bimanual compression, all that also does not need to be done. So that is the, beauty of this drug, which gives us the ease to use this drug more easily. And I would definitely want each of us to, use this drug and take your own understanding of the drug. Use it. First, use it and see. If you feel that this drug has made a difference, definitely, I'm sure it will make a difference to your thinking and your mindset. Comparison was done as against other intervention, and they thought the prophylactic treatment with carbetocin after an elective C-section reduces the need for addition. So it's not just for vaginal delivery I'm talking about. I'm even talking about speaking about a elective C-section where just as the baby is delivered, you give the carbetocin and you will see that the placenta separates out immediately and is right at the incision point. So you don't even need to, go in and separate it. It's already out. So that is the beauty, and that is how much you prevent the blood loss. I mean, why should a blood be wasted? Why not prevent even that much? Why should a woman have 100 or 200 ml loss also? Okay, these are another studies which were taken. Reduction in PPH, blood loss, smaller drop in hemoglobin level, and less adverse effects makes carbetocin more effective than the symptometrin. So we know that even the combination drug as well has, not been a better version. When we know that oxytocin and methergin combination has not made a major change even with the carbetocin. So carbetocin is still superior or stable as compared to them. Look at the adverse effect, the GI effects here. Look at this and this. You can make out how much of nausea, vomiting, headache, leukocytosis, arrhythmias, palpitations, fall in the blood pressure, skin rashes are seen in the oxytocin as compared to carbetocin. So the safety profile is so much better of carbetocin over all other uterotonics. So I would definitely say that it is a promising agent for PPH prevention. So we must embrace it in a better way. Whenever something new comes, we have to look at the pros and the cons. And if you feel the pros are much, much better, leaving aside our ego, leaving aside our old thought, school thoughts that, as a student, I'm not aware of this, I don't want to change this. I think we should all shed that inhibitions from us and accept the newer version and use it, because we are not just using it for us, but we are using it for the safety of our patient. And we have to look that saving even one patient will bring our MMR down. So intramuscular administration of carbetocin at a dose of 100 microgram is more effective than oxytocin for preventing PPH. Its use is associated with, it's the same thing that I've been speaking over and over again through the slides, to just, put that in your mind, that this drug has such a lot of promising role in preventing PPH. PPH is never going to be obsolete, because even if you use it as a preventive prophylaxis, yes, we will still have a few patients who will need a much more interventions and invasive method also. But for those who would be avoided with the invasive method, can be prevented. So at least the numbers can definitely come down. In women who underwent C-section, the risk of PPH was lower in the group receiving carbetocin, as I just spoke to you all about the medication which I use. Compared with all other uterotonics, it's superior. Effects with the other drugs like misoprostol and oxytocin, it showed a better efficacy. And so when we look at the efficacy, it is not that it is very much better than this drug over that drug, but of course it does not have its adverse effects also, which is more welcome to any patient. I mean, if you have a person telling you that, with this drug, you'll get vomiting, like having a chemotherapy profile, who would like to have vomiting, retching after a drug instillation? So imagine that if you instill a drug and the patient does not have the adverse effect, how much comfortable that patient will be and how much you will be at ease looking at that patient. So our guideline recommendation, as I said, in all these countries with all the societies today, they have included carbetocin in the PPH prophylaxis. WHO almost in 2018, the Canada Society in 2009, the New Zealand one in 2017, FIGO has done it, Germany. So I think it has covered most of the countries. So why not we Indians embrace this drug? So my key messages will be that PPH remains clinically significant cause of maternal complication and death, as we have known it from the past to the date, till date. It is common and can occur even in women who are not. We know that there is no factors. A low risk can suddenly become a high risk, and we have to be completely alert while we deliver any or every patient. PPH has a major impact on the lives of the patient, their family, the healthcare society, and thus there is a lot of affection in that way. So we have to prevent that. WHO recommends the use of prophylactic uterotonic as an important step in the active management of the third stage. This could reduce the risk of PPH by more than 40%. Imagine from 70, bringing it down to 40 will make what a difference. I'm sure there'll be some other change or newer drug that will definitely come in the market one day, which will even eliminate that 40%. Carbetocin is a synthetic, long-acting analog of oxytocin created by making, so it is oxytocin with certain changes and made more stable as compared to oxytocin. So why not accept the newer version of oxytocin, then sit with the old version? And it is available in a vial form, stable at room temperature, has a similar efficacy and safety profile. I would say a better safety profile than even oxytocin. And it reduces the need of the combination extra uterotonics, reduces the blood loss to even less than 200 ml. So why should you allow a birthing mother to, give away her blood, waste it to just nothing? So these are the studies, these are the comparative studies, these are the societies who have recommended and used it. So I believe that Carbi Act, that is the carbetocin 100 microgram, which is in single ml, has been a savior to all the women, and definitely it has reflected on the healthcare. That is the healthcare professional who has used this has vouched for it. And I have known my colleagues who were not using it, and we convinced them, and believe me, they all came back and said, yes, thank you so much. So thank you very much. I hope I have done justice to the slides and to the subject that was given to me and to the drug that is in the market to be utilized in the right way forward. Thank you so much.
Yes. Thank you, madam. It was a wonderful session, as I told you. Your sessions are always like a CME. You go in depth without us realizing, how beautifully. But one thing really take home message is always overtreat and not never undertreat. Is a really key
Absolutely.
message.
Yeah. The
And
key.
expect the unexpected. You do not know which patient will land where.
Yeah. So I
A
mean,
few
I'm sure
questions, madam.
those audience who are, those doctors who are listening to me, I definitely will agree with me that PPH is so
Correct.
unpredictable. It's so unpredictable.
Absolutely. Absolutely. One thing, madam, is a contraction, the force and the rate of contraction frequency with oxytocin and carbetocin. Is carbetocin superior, force and
So
frequency?
So what I would say is there is no superiority of oxytocin over this. But the thing is,
Huh.
when we are using oxytocin, it depends on where we are using it. If I'm using it in a
Okay.
smaller sector where the cold chain has not
Okay.
been maintained,
Okay.
it may not show its
Huh.
efficacy. So I won't say that
Absolute.
it is not a
Absolute.
drug of choice. It is a
Correct.
drug
No,
of
no,
choice,
no.
but
It
we are not
cannot be.
able to
Of course,
maintain
it
its
is.
efficacy.
That's a
That's the
different
only
story.
reason that carbetocin is superior over that we don't need to maintain the,
Cold chain.
yeah.
And can we say that use carbetocin prophylactically in every delivery to prevent PPH? Or it
Why
would be too
not?
loud a
Why
claim?
why not? Why would you want a patient to have a PPH in the first
Exactly.
place?
Exactly.
Why
Exactly.
not prevent
Pre-
it?
exactly.
Better
And
sorry.
prevention is always the best.
Yeah, yeah.
Yeah.
Better safe than sorry is what our
Absolute.
statement should be.
Absolute.
We have to have a
Absolute.
safety profile, then feeling sorry for
Correct.
the patient and to ourselves.
Absolutely. Yeah. 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 And how frequently, madam, after using carbetocin, you have to use second line drug in your practice?
Um, Very rarely. I would say with so many, I think one or two patients I have needed. That is over a year that I'm talking about.
Okay. Okay.
So
So
it is
not
very,
really
very,
much.
yeah, not much, not
Okay.
much.
Okay.
Not much.
And as a second line, what is your preference? A methergine, a misoprostol, or what?
I would still prefer a misoprostol. I use the
Misoprostol. Yeah.
purectal form just to be,
Correct.
that
Correct. Correct. It's very
along with
convenient
this,
to give also.
there is a prolonged this with misoprostol rather than, having
Absolutely.
other. I believe in not
Absolutely.
having adverse effects in the form of nausea, vomiting also in a patient.
That's correct. That's
Why would
correct.
you want the patient to have the GI symptoms?
There's a moment of joy. Na? I mean, that joy is ultimate. And at that time, someone gets nausea, vomiting. Think about the
Yes.
lady. Na? Think
Yeah,
about the
you know
family.
how it feels.
Yeah.
I mean, it is for us
I know.
also.
I know.
You
I
eat something,
know. I know.
eat a candy, and then you have to vomit off.
You'll
You will
believe me,
feel
madam, when
horrible.
my daughter, yeah, when my daughter-in-law delivered 2 years back, the first thing I was asking is placenta out and all controlled. I did not ask anything else.
No, no, I'm telling you, it is completely nightmarish. When a patient
Correct,
goes into
correct,
PPH,
correct.
you go into a complete fog at the moment because,
Absolutely.
it is so dreadful situation seeing that woman
Right, right.
in a pool of blood and then you have nobody. Sometimes who's there
Suddenly,
to relate to
suddenly,
you? You have just
yeah,
one
yeah.
sister,
Suddenly it
one
dips.
maushi and you in a nursing home sector. So
Suddenly it
that's so
dips.
important that you have a good nursing staff.
Correct, correct,
So
correct,
I
correct,
just feel that why wait for disaster?
correct. And another question is, any incidents of renal failure, etc., with carbidosis? Of course, it's a single
No,
drug,
the
it's
safety
single dose, so
profile
I
is
wouldn't expect.
absolutely fine. Absolutely fine. I've not come across
And
any
diabetics,
in
diabetics, we
diabetics,
can give
in
this.
PIH, in patients
Okay,
with all of this high risk
okay,
profile. Carbetocin has
okay,
done a good job. Certain heart
absolutely.
conditions, well, I've not used
Yeah,
them. They say to be a little more careful, but other than that,
obviously.
no. So the
Right, madam. Thank you so much. It was wonderful as usual.
Yeah, thank you so much.
Thanks, it's
I
very
hope I
much.
didn't bore all of them. I had to
No,
repeatedly
not
the
at all,
same
not at
sentence
all,
again
not
and
at all.
again, but that was for me to highlight.
This is a very important topic more than anything
Yeah,
in terms of
and
understanding.
this
Thank
topic
you so
will
much.
always be important, Dr. Prashant.
Absolutely, absolutely, absolutely. Thank you.
Yeah. Thank you so much to Hetero, Dr. Prashant, and all the doctors who
Pleasure,
were
madam.
listening to me. Thank you so much, and have a
Thank you.
good evening.
Thank you.